Welcome everyone, and thank you so much for joining today's webinar. Today we have Dr. Jennifer Reckrey to discuss Caregiving Together, the relationship between paid and family caregivers. Just a couple of housekeeping items. All attendees are muted and video cannot be turned on. We also ask that you please use the Q&A feature to type in your questions. And if any questions that come up are more technical, like if you're having trouble hearing, we ask that you please use the chat feature and we'll do our best to help with those. Please share your questions and comments at any time, and we'll answer those in the last 20 minutes of this webinar. Also on today's panel is Dr. Christine Ritchie, co-chair of the PCRC. So I think we can get started, and I'll ask Dr. Ritchie to please formally introduce our speaker.
Thank you, Naomi, and greetings, everybody. We're so delighted to have you here to learn about a very important issue that's often underaddressed, and that's the experience of the caregiver living in the community. So, and we're so happy to hear from Dr. Jennifer Reckrey. Jenny Reckrey is a geriatrician and clinical researcher in the Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. After her family medicine residency at the Montefiore's Department of Family and Social Medicine in the Bronx and her geriatric medicine fellowship at Mount Sinai, she began work providing both home-based primary and home-based palliative care in Mount Sinai's Visiting Doctors Program. Through both her clinical and administrative work, she began to appreciate the important but often unacknowledged way that caregivers work with the home-based care team to enable persons with serious illness to live at home through the end of life. As a result, she shifted her career to focus primarily on research and is currently the recipient of a K-23 from the NIA to study the role of paid caregivers in the home-based dementia care team. This particular webinar is a webinar sponsored by our Caregiver Corps, and we're so glad to have Dr. Reckrey come and help us think about some important issues around caregiving and caregivers. Thank you, Jenny.
Great. Thank you all. Thank you for the opportunity to present about the relationship between paid and family caregiving. I hope with this webinar to really sort of introduce you to the role of the paid caregiver, but also encourage people to think sort of in a more nuanced way about caregiving and hopefully find ways to use that in your own work. So you can feel free to ask questions throughout the webinar. I can't see the chat, but Naomi can jump in and let me know if people have questions. But as Christine said, there's also room for questions and time for questions at the end. So I want to start with what I see as the main question that informs my clinical and research work. And that is, what does it take for someone to live at home through the end of life? As Christine said, my passion is really primary care, and my practice as a home-based primary and palliative care provider has really shown me that, that it takes a lot for someone to stay at home as their serious illness progresses. I think, this audience in particular really understands the importance of the interdisciplinary team in making that care possible. And this includes sort of both the formal team, but I think also it includes a sort of broader or loosely defined team, because the reality is lots of people are working together to keep somebody at home. And I think a core part of that team, and I think you would agree, is the family caregiver. Again, I don't think I have to convince you all of the importance of family caregivers. Just a tiny bit of background. 1 in 5 US adults are a caregiver, and about 60% care for people with chronic illness or disability. So caregiving is clearly really important. But I think it's also important to remember that the conceptualization of sort of a single primary caregiver is really inadequate. Individuals at the end of life report on average 2.5 caregivers who help with functional needs. And this doesn't take into account the many other ways that caregivers help, things like emotional support or care coordination. Related, caregivers are often caring for more than one person. So a child caring for both parents, or a spouse caring for their spouse, but also a neighbor. This caregiving network is often really quite broad. And I think, as we think more broadly about caregiving and what it means for people, how people put that care together to be able to meet their goals and stay at home at the end of life, if that's what they want, I want to focus on another part of that caregiving team, and that's the paid caregiver. So paid caregivers you may know by other names: home care workers, direct care workers, formal caregivers, lots of different ways of talking about this group of people. I like paid caregiving mostly because it sort of emphasizes the care part, and I think that that's really the most important. Paid caregivers include home health aides, hospice aides, home care aides, personal care attendants. In New York State, we call them home attendants. But there's lots of different names for these care providers. And while there's many distinctions between groups, there's also a lot of similarities. I just want to touch briefly on some of the distinctions. So home health aides and hospice aides work under the supervision of a registered nurse, and that group is required to meet federal and sometimes state training requirements. And so that is 75 hours of training and completion of a competency exam. The other group, which is the personal care aides, home attendants, the training that's required really varies by state, and about half of states actually have no training requirements for this group. And this group often provides care that's not medical in nature, and they don't necessarily have that nurse supervision. And there's some differences between groups. So hospice aides earn slightly more sometimes and tend to be more satisfied in some studies. But honestly, there's a lot of fluidity between categories. And clinically, I've had the experience where where people have been calling themselves home attendants, and really they actually have that home health aide training. I think there's a lot of fluidity between categories, and people move from being a hospice aide, for example, to a personal care attendant. So again, the groups have some meaning in those distinctions, but there's a lot of similarities. And I also just want to mention too, consumer-directed care. So this refers to programs for individuals who qualify for government-funded paid care, but where they choose to hire and manage their own paid caregivers rather than going through an agency. And many times who they choose to provide care is a family member who then gets paid to provide care. This isn't the focus of my work, so I won't spend a ton of time here, but I just wanted to mention that, that this is also, there's also a good amount of fluidity in consumer-directed care. Naomi Galopin has done some work about this, kind of looking at how, like, for example, family caregivers sometimes are paid for some of their hours of care through consumer-directed programs, but spend hours of care outside of that as well. Or people who are paid caregivers working through an agency in a more formal way, got into it because of their family caregiver role, or people who used to be working through an agency but then take time off and provide care to family members. So again, a lot of fluidity, but ultimately, people who are really in that direct hands-on way providing care for people at home. I think, one more piece of background that I think informs a lot of the discussion is how people actually end up getting paid care. So there's several ways. First, through Medicare or a private insurance, people do receive paid care, but this tends to be short-term care only. So this is often through a certified home health agency or through hospice. If people need care in a more long-term way for functional disability or impairments that's not just related to a discrete event, people sometimes rely on long-term care insurance, which can pay for paid caregivers in the home. Unfortunately, not a lot of people have long-term care insurance. I think it's about 8% of the US population who has it at this point. And so that's actually a pretty minor payer for paid care in the home. The biggest government payer for paid care in the home is Medicaid. But the hard, one of the challenges is that there really is a lot of variability state to state in terms of what Medicaid pays for. There's a really great resource. It's the Long-Term Care Services and Support Scorecard. It's available online. The 2020 version just came out. It's sponsored by AARP and the Commonwealth Fund that actually looks at states and ranks states on various aspects of their long-term care services and supports. One that's relevant for this conversation is the percent of the state's Medicaid spending on long-term services and supports that goes to home and community-based services versus institutional locations where people get long-term care, like nursing homes. And you really, when you look at those numbers, you can see this variability. So in Alaska, for example, over 80% of their Medicaid long-term care spending goes to support people in, to home and community-based services. On the other end of the spectrum, North Dakota, less than 30% of their Medicaid long-term care spending goes to home and community-based services. So again, the options for care through Medicaid or other government programs can really vary state to state. And the final category is private pay. So this sometimes is through an agency. Sometimes people are paid, are just paid directly. Sometimes this is, this is people file their taxes, but a lot of times this is sort of the gray market. And this category I've seen, maybe between 50, 70% of paid care comes through private pay. So the reason I spend a little bit of time talking about how people get paid care is that it really has significant implications for who gets help. So this figure comes from a study that I worked on using NHAT, so the National Health and Aging Trend Study. And what we're looking at here is the percent of people who have paid care on the y-axis, and then the income quartile on the x-axis. And what you really see, the gray areas are those who do not have paid caregiving. So you can see the vast majority of people living in the community do not have, with functional impairment, and in the case of the study, it was with dementia, do not have paid care. But what you can also notice here is that there's a little bit of a U shape to the curve, right? So the highest rates of paid care receipt are in either the lowest income quartile, where most likely people also have qualify for Medicaid, and then in the highest income quartile, where again you can imagine that they're able to private pay. There's a lot less paid care in that middle income area, and I think this just sort of highlights issues with access. And when we have a system of paid care that really is sort of a patchwork system like it is here in the United States, where the care people receive is not just based on their need, but based on many other factors, including income, you have the potential to see lots of disparities in terms of who has access to care that they need. So much of the existing research that's out there about paid caregivers really focuses on the paid caregiver workforce. So, a few important things to point out. So, most paid caregivers are women. Many come from racial and ethnic minority backgrounds, many immigrants. There is currently, and it's expected to get worse, a shortage of paid caregivers. So in many places, even if you have money to hire a paid caregiver, it may be hard to find somebody who's able to work for you at home. Training and oversight are really variable. Again, varies state by state, and what paid care looks like in one place is very different from what it would look like in another. Paid caregivers are often really remarkably underpaid. So in 2017, the average was $11 per hour. Leading Age actually just came out with a really interesting study looking at what the kind of financial impact of paying paid caregivers a living wage. And it's interesting to kind of look at and see, what, even though big picture, this would support people and allow for kinds of care and improved caring experiences, there's a lot of challenges to making something like that living wage happen. There is also few pathways for advancement within the paid care. So unlike nursing, for example, where there is, additional education, additional responsibility over time, often for paid caregivers like home health aides and home attendants, there isn't that opportunity for advancement within their field. They have to kind of leave the field in order to move up. And finally, what I kind of see as the most fundamental piece here is that the care that paid caregivers provide is really viewed as unskilled, and as a result, not valued. Just as an example, paid caregivers were actually not protected by the Fair Labor Standards Act. So this is what guarantees minimum wage, overtime. They weren't protected under this act until 2017. Before that, there was what was called the companionship, or known as the companionship exemption, which basically implied that paid care was kind of like babysitting, and that because of that, the rules that would apply to more formal labor wouldn't apply to that group. So I think this workforce literature is extremely important, and I think really talks, can give us a lot of insight into how paid caregivers are seen relative to others in the healthcare system. But what I think is also true is that there's really a big gap here. Like, paid caregivers are not studied in relation to those they care for or their families. And I think the assumption is that the care they provide is really about completing a task, and that paid caregivers themselves are interchangeable. There's examples of this in many ways, but I just want to point out the example of hospice aides. A hospice aides are an important part of hospice care and the hospice team, but actually discussion of hospice aides and their role is really missing from the literature about the hospice interdisciplinary team. I can think of so many questions related to this. When do hospice aides become a part of care? Why are hospice aides involved in a hospice episode? What is their role? Are they providing help with a specific task? Is it more about respite for the families? And really, sort of most importantly, how does their care impact the experience of patients and families? And the corollary of that is, how can we make that care better? Yet, sort of the basic research, some of the information that we would need just to understand what's happening right now is missing, because again, the paid caregivers are not studied in the relation to patients and families. So, to go back to my experience in home-based primary and palliative care, it was really obvious that, most of my patients with serious illness and functional limitations just would not be able to live at home without paid care. And, from my perspective as a physician, the medical care that I was providing was really dependent on the long-term care provided by paid caregivers and family caregivers. So, my initial research into this question, or my initial project, involved conducting semi-structured interviews with dyads of homebound individuals or their family caregiver if the person had dementia, and the paid caregiver. And learned many important lessons in this first project, but two things I want to highlight. So the first is, the importance of some of the power dynamics that were at play here. I actually found that paid caregivers were very happy to talk with me, but they really voiced a lot of fears related to retribution from agencies or from the patients they cared for or the families, if they upset anyone. They didn't feel a lot of agency in this situation, and I think as a result, the ways we talked about the care they provided were very different. The second thing to point out is that, it's hard to ask people to talk about something they've never considered. I think, I talk about sort of from a societal perspective, we don't value this care that paid caregivers provide. But I thought, I felt talking with paid caregivers, patients, and families, that care wasn't always valued by them either. To kind of give a specific example from that project, I was really interested in understanding, like, literally, what are paid caregivers doing in the home? Is it, what's going on? And when I asked that question, the response that I got was very much sort of a list of functional tasks. So they said that paid caregiver cooks and cleans, and I would say, are they doing anything else? And the answer was no, they're doing those things that they're supposed to do. But when I asked people what happens, what happens when this person got sick, what happens when they felt short of breath or they had pain, I got a much longer list of things that paid caregivers do. And, some of the work that came out of it was just sort of enumerating these tasks. So, for example, there were many tasks related to addressing acute medical issues. Paid caregivers talked about the work they did convincing patients to get needed care. They assisted with chronic disease management, so much help tracking health needs, tracking appointments. They helped with promoting general health. Paid caregivers and patients themselves talked about how the paid caregivers sort of took it upon themselves to ask their care recipients to to eat well and to keep them exercising and mobile. This wasn't sort of part of any formal care plan, but it was a big part of their role. And finally, paid caregivers work to promote mental health and well-being. And, some of this is emotional support, but also more broadly, attention to making care recipients happy, to making their lives better, to helping them have a quality of life. And so, not surprisingly, based on some of these kind of hierarchies that we've talked about here in the power dynamics, there was actually little evidence of communication between paid caregivers and the more, the formal healthcare team. So physicians, nurses, even communication with the agencies and the nurses who were supervising the paid caregivers was actually quite minimal and often very reactive. But one other sort of important theme here that has guided my kind of subsequent work is looking or thinking more about the dynamics of the family and paid caregivers for individuals with dementia. This I found particularly interesting because with dementia, it's really a unique situation. So obviously the individuals with dementia themselves have really high levels of functional need, but the paid caregivers are often taking on really high levels of responsibility in these care situations because the individual with dementia can't advocate for themselves, and families are very involved but may not be there at the time when care is being provided. So in subsequent work, I used NHATS, so the National Health and Aging Trend Study, to look at the prevalence of and factors associated with receipt of paid care, again, among individuals with dementia living in the community. And I was surprised that only 10% of people living in the community with dementia had paid care. The rates of paid care, though, were much higher among those with advanced dementia. About half of people with advanced dementia had paid care in the home. And paid care was more common among men, those who were unmarried, those who had Medicaid, and those with greater functional impairment. I think this was also really interesting data to look at, though, because we were able to see a bit more about that balance between paid and family caregiving. So in this figure, you can see on the y-axis is total weekly hours of caregiving support received by the individuals with dementia. And on the x-axis, you see dementia, sort of everyone with dementia, and then that subgroup with advanced dementia. And you can see among those who received paid care, both in the sort of dementia group overall and in the advanced dementia group, paid care was about a little less than half of the total care hours. The rest were families. And, when you see the graph kind of like this, the question becomes, how are families working with paid caregivers? What does that look like? And how is that important for patients and families? So, this is sort of how I have come to conceptualize some of these relationships. So you have an individual with dementia who is receiving paid care and family care, and there's really sort of dynamic relationships between everyone here. This care exists obviously within a healthcare system that offers medical care, but also long-term care, which is informed by the community and again by that larger health policy and workforce context. And what I actually am most interested in is why this matters. And I think that, these relationships between paid caregivers, family caregivers, individuals with dementia, how they work together to keep people living in the community makes a difference. And so it matters for the paid caregivers themselves, and it matters for the individual with dementia, and it matters for their family caregivers. And it's sort of this piece, how this care arrangement matters for family caregivers that I've sort of come to focus on in the last year in particular, and that I want to talk a little bit more about today. So the question is, though, how to do this, right? How to understand and get at what's really happening here. So kind of considered two approaches. So I've done some work with secondary data analysis, again, using NHATS, and also the National Study of Caregiving, which is a linked study of the family caregivers of individuals who are enrolled in the larger NHATS trial. So this is a great idea because it's a nationally representative data set. And actually NHATS does have data on paid care hours. So many studies don't ask about paid care, or if they do, it's sort of a yes/no piece. NHATS does have more information on paid care hours. The con here, though, is that that's what they have is paid caregiver hours. So this data is really focused on quantity. It's focused on the sort of functional tasks, but there isn't any information about some of the more dynamic relationship factors that could be involved, and also, things about how this little caregiving group has been working together. Next option, obviously, is primary data collection. surveys can be very resource intensive, but I came back to that question of, well, what do you ask? You know, if people haven't thought about this before, how do you, in one word or one sentence or one multiple choice, ask a meaningful question and get an answer that reflects what's really going on? So I turned to qualitative data, which I think is great because it does capture the nuance and identify themes. The cons are largely, as I said, paid care is very variable depending on where people are. And I've struggled with my own qualitative work on this topic to understand how the experience of paid caregivers and patients and families here in New York City, where I am practicing and where I'm conducting my research, how that connects with the larger experience nationally. And so that's definitely a concern. And second, again, the power dynamics here are really important and limit, I think, some of the things that can come up in conversation. So perhaps not surprisingly, as I've looked at this, I've actually tried to adopt both approaches and take what they have to offer and try to kind of think of them as complementary. So I've done an evaluation of the relationship between receipt of paid care and family caregiver experience using NHATS and NSOC, and also one-on-one semi-structured interviews via phone or Zoom with family caregivers of individuals with advanced dementia enrolled in my home-based primary care program. I think the results are complementary and reveal really important themes. The one caveat is just that I'm finalizing analysis for both of these projects. So I'm going to present results that are a little bit in process, but again, I think give a good sense of the potential ways that paid care makes a difference for families. So first, in the secondary data analysis using NHATS and NSOC, we identified 338 observations from individuals living in the community with advanced dementia. So this meant drawing patients from several waves. So the NHATS study is done yearly, and at sort of points within there, they do the NSOC, so the complementary analysis of family caregivers. So we use data from 2011, 2015, and 2017. NHATS identifies those people with probable dementia, and we looked for those who had at least one caregiver interviewed in NSOC, and then limited to those who had advanced dementia, which we defined as people who reported impairment in dressing, bathing, toileting, as well as managing meds and finances. So a little bit of a rough estimate, but more or less a FAST score of 6 or 7. And we categorized individuals based on receipt of no paid care, part-time paid care, so less than 40 hours a week, or full-time paid care, and then looked at the associations between quantity of paid care and the caregiving experience. So just, it's a brief overview of the results. About half of these individuals had no paid care, and about 20% had full-time paid care. And, surprisingly, there weren't that many differences between the groups, the full-time, part-time, and no paid care groups. And all three groups had similar numbers of family caregivers. So on average, between 2.3 and 2.5. It was striking, though, that the number of hours of paid care that people received was very different. So those who had part-time paid care averaged about 14 hours per week, whereas those who had full-time paid care averaged almost 96 hours per week. And so these are some of our results looking at the family caregiver experiences. So you can see on the y-axis there, we have different negative family caregiver experiences. So exhaustion, financial difficulty, and on the x-axis is the percent in each group endorsing the experience. And the different bars are those who had full-time paid care, part-time paid care, and no paid care. And as you can see, kind of in general, those with full-time paid care had less negative caregiving experiences. The differences, though, weren't always statistically significant. Results related to exhaustion or feeling like you have more to do than you can handle, no time for yourself. There was significance there, but the questions about difficulty, financial, emotional, and physical difficulty were not statistically different between the groups. We then looked at some family caregiving experiences related to activity restrictions due to caregiving. So, for example, caregiving kept you from working for pay. Caregiving kept you from caring for other people. And here the differences are, even more striking. So those who received full-time paid care were significantly less likely to report most all of these activity restrictions. I think it's also worth noting that the experiences and the activity restrictions that those who had part-time paid care reported were basically the same, and sometimes a little more than those who had no paid care. So, obviously some of the effect of this is obviously just the number of hours that those that family caregivers provide care. But this table presents results from multivariable models, sort of looking at the association between full-time paid care and negative family caregiver experiences. So the negative experiences are high caregiver strain. So this is using a previously validated strain score index related, the mean strain score, and finally any reporting that caregiving caused any activity restriction. And as you can see, the relationship between full-time paid care and less of these negative caregiving experiences was somewhat attenuated when you adjusted for characteristics of the individual with dementia themselves, so their age, the degree of impairment, and when you adjusted for characteristics of the family caregiver, so things like their gender, whether they live with the care recipient, if they're a child of the care recipient, and then the hours of care that individual is providing. But as you can see, there still is this relationship between full-time paid care and the family caregiving experience. So the second approach is family caregiver interviews. So, for these interviews, these were conducted over the summer primarily. And we started sort of as a jumping off point for the interview, talking about paid caregiving during COVID. But pretty quickly, these led to discussions more generally about how paid care impacts patients and families. So there's 15 interviews have been completed, and we're working on the coding and analysis now. But just a little information. So this is the patients actually are largely of Hispanic background. Most have Medicaid. They're very functionally dependent, and all of the individuals with dementia had at least 12. At least 12 and most often 24 hours of paid care. The family caregivers were mostly daughters who didn't live with their parents. So, I want to just present a few of the emerging themes. Again, I think that they really help inform our understanding of these relationships. So the first is an excerpt from an interview with a daughter in her early 60s, talking about the care of her 92-year-old father. And, in this quotation, she was talking about what it was like for her family before her dad got home care. And in particular, she was talking about how it impacted her son. She told us, "My father would call my son and say, 'I'm hungry,' at 2:00. And when my father didn't have home care, my son would constantly go every day and see him and check him. And then my son got a very good job where he couldn't leave until 6. My son left that job and resigned. I was telling him, 'Why did you do that? You needed to stay in that great job.' And he was like, 'Because when grandpa would call me and say I'm hungry at 11, I was telling him, I can't feed you. I can't bring any food till 6. It broke my heart.'" I think, in these interviews, we also had a lot of discussion about what makes a good paid caregiver. And quite honestly, I heard a lot of really, horror stories about really bad care and frankly, negligent care from paid caregivers. But there was also more nuanced discussions of relationships between family and paid caregivers and the importance of stability. So this quotation, it comes from a daughter of who's in her 50s, and she's describing why she's grateful for her current paid caregivers. She says, "When you're changing paid caregivers constantly, it's like resetting constantly. The individuals with dementia get agitated and confused, and then you don't know whether it's the medicine that's making them confused and agitated, or whether it's just that they're not in sync with a new person. It works out a lot better when you have stable people who are good and a good fit." And finally, another daughter in her 50s sort of described what it's like to provide care for a patient with dementia and how the paid care that her father with dementia received mattered to her. She said, "I know people my age who don't have a home care person, and they are the home care person themselves. It's very stressful and it impacts your life in every social aspect, in financial aspects, in every way. So you're trying to juggle it all, and eventually you get exhausted, you break down, and then that doesn't help the senior at all. So yes, the home attendant really relieves that pressure. So, considering the studies together, I think we can, draw some more nuanced conclusions about how paid caregivers impact families. And I think the first piece is that paid care really seems to afford family caregivers the time to engage more fully with other aspects of their life. It doesn't take away from the emotional difficulty or even the physical difficulty necessarily, but it helps make these often intense family caregiving responsibilities sustainable, which again, for this group of dementia caregivers is especially important. But when the care isn't right, when there's a wrong fit, when there's not a regular person, when the hours are minimal, it doesn't have that same impact. And, we found evidence that paid caregiving arrangements can be better or worse. And that sometimes for the family caregiver, having paid care in the home itself can be a stressor. And so it's important to consider each of these caregiving arrangements as really highly individualized. So, to return to my initial question, what does it take for someone to live at home through the end of life? And as you can see from the work I've conducted, I think what it takes is somebody to help you, and most often more than one person to help you. So as I get towards the end of my presentation, I just want to close with a few lessons that I have learned in the course of my work, or I'm learning in the course of my work, that I think may be helpful to others who are thinking about the role that caregivers play in the lives of those with serious illness. So I think first is just the assessment of the caregiving situation, caregivers' willingness and ability to help. It's just really important. You don't know unless you ask if that person who you're caring for has that 24-hour live-in paid caregiver who kind of makes everything run, or if there's somebody who's there on and off to help with bathing, but that's about all. So you don't know unless you ask. And I think this requires really acknowledging the nuance of care arrangements. This does not mean that you'll necessarily incorporate this into your study or your intervention, but I think it's important to acknowledge. So even if that nuance is not something that you can address directly, if we don't talk about that nuance, it's almost as if it isn't there, and it oversimplifies situations where there really is a lot going on. A second point I want to bring up is that, in this caregiver assessment, it's not enough to just know that there are caregivers. Is there any paid care or no paid care? You really need to figure out a little bit better what people are actually doing. So this is related work I just want to share briefly. This is, again, using NHATs and a sort of different group of people. This is looking at individuals interviewed in NHATs who reported impairment in toileting, so that they had difficulty or needed help with toileting. And that's an important impairment, just because this impairment in toileting is associated with nursing home placement and medical complications like pressure ulcers. And so, nearly all of this group with that had impairment in toileting had caregivers. Only about 2/3 actually said that their caregivers helped them with toileting. And to kind of tease this out more, what you're seeing here is a proportional Venn diagram that shows the groups who get these types of assistance. So sort of high intensity caregiving, right? So the yellow circle there is high hours of care, so that they get caregiving support more than 40 hours a week. The blue circle is high number of helpers, so 3 or more helpers. And the red is those who had targeted assistance with toileting. And there's a lot that overlaps, but I think it's really notable that there's a lot that doesn't overlap, that there are people who have clear care needs, who may have care 40 hours a week, who may have many people in there helping, but unless you actually ask what those people are doing, you might miss the fact that those caregivers are not helping with in this case, toileting, or helping with a very specific need that has real consequences for patients. So second, I wanted to emphasize the ways that I think this work has allowed me to embrace and actually really enjoy flexibility, enjoy the complexity, and adopt a sort of flexible approach, really matching the methods to the questions and considering multiple approaches to answer some of the most complex questions. I think related to that, and a part of the complexity as well, is sensitivity to the vulnerability of the subjects who we're looking at in our research studies. And, individuals with serious illness and those at the end of life are very vulnerable. Individuals with dementia are very vulnerable. But I think my work has also revealed that the paid caregivers who are taking care of them are also very vulnerable. And being aware of that, being aware of how those vulnerabilities play out for people's experiences of care and their ability to advocate for what they see as the right thing, I think is really important. And I think when it comes to paid caregivers, really acknowledging that paid caregivers are some of the lowest people on the healthcare hierarchy, and they may not feel like they have a lot of control over the care that happens in somebody's home. I know, we would all want to be a part of collaborative care teams, but there's barriers to that mutual respect that is essential for real team-based care. And finally, because there really is minimal health-related research about paid caregivers, I think that for my work, the background that really drives my questions comes, of course, from my clinical experience, but also from this workforce literature, and from existing health policy. There really is an interrelationship between policy and clinical care. And, I think having work be informed by both is really important. So to conclude, I just want to say again that, I think that family and paid caregivers really share in the goal of supporting those with serious illness at home. And, and I think for those of us interested in research about caregiving, this creates a lot of opportunity to improve the experience of both groups, honestly, of the family caregivers and of the paid caregivers too. So specifically, I really believe that family caregivers should engage more deeply and advocate more vocally around issues important to the strength of the paid caregiver workforce. So these are issues about training, issues about compensation, paying people a living wage. I think these matter to family caregivers and their family caregiving experience. And the flip side of that is that the needs of family caregivers should be prioritized in discussions of what contributes to quality paid care. What paid caregivers are doing in the home is caring for the care recipient, obviously, but this impacts sort of the whole care unit. And I think understanding the ways that paid and family caregivers are interdependent opens up new ways, I think, to help them and to help the patients who they care for. So thank you all for being here, and I appreciate being able to give this webinar. I'm happy to answer any questions, and thank you.
Thank you so much, Dr. Reckrey. If there's any questions, please do put them in the Q&A feature and we'll get to those.
There is one question in the Q&A. Maybe we can start with that. And it says, in the study described by you, Jenny, did the paid caregivers have respite periods when they went off the job briefly to rest?
So that's a really good question. I assume that by the study you're talking about, the qualitative project, many of these 24-hour or the kind of live-in paid caregivers are work shifts. So they work like 3 days on. So one person will work 3 days, one person will work 4 days. And during that time, I know in New York City, and again, this is where, I may not be speaking to some of the nuances in different places, but for these paid caregivers in particular, when somebody is there for a live-in position, so 24 hours, they're actually paid for 13 hours. They're expected to stay there, obviously overnight, and potentially be woken up a couple times to do, to provide care, but are paid for 13 hours. So many of these, many of the caregivers who I interviewed talked about paid caregivers who had worked with them for years. One person had 2 paid caregivers, sort of alternating 3-day and 4-day shifts. One had been there 8 years, another had been there 2 years. And so, it didn't start that way. Many of them had gone through a lot of people that didn't work right, but when they had these relationships, stable relationships with caregivers, many described it as like family.
Great. Next question for you, Dr. Reckrey, is could you give some examples of the interview questions that you asked?
Yeah. Well, so when I started the interviews, I kind of, again, kind of used COVID and what it was like during COVID as the grounding point. So we started by sort of saying, COVID led to lots of changes. How did paid caregiving change for you during the COVID pandemic here in New York City? And people, I was actually surprised that it didn't change more. I think for many people, the paid care was what was essential. Family members talked about staying away from their loved one during that time to limit exposure, but for the people I talked to, paid care continued. I asked things like, I tried a lot to compare and contrast current and previous paid caregivers. So, people often really liked and respected and felt close to the paid caregivers who were there. And I said, what did they do that's different than other paid caregivers? What did that process look like over time? I think, many of the questions that I found to be most useful and to really get at some of the most nuanced and sort of thoughtful responses came from sort of contrasting the good paid caregiver and the bad, contrasting what it was like before there was paid care in the home and what it's like now. I'm
Great.
also happy to share any of this if people want to talk individually or would like to see the questions. Please reach out because I'm more than happy to share things in more detail.
Thanks, Julie. And this question sort of relates to what you were just talking about, and that is, do we have any insights into predictors of stable paid caregiving?
Yeah, I'm really interested in this. And, as Christine mentioned, I'm now I have a K-23 and I'm working on some qualitative research as a part of that. And the project that I'm doing is actually, it's a longitudinal qualitative project where I'm interviewing the family caregivers of individuals with dementia, as well as their paid caregiver, a primary paid caregiver, and their healthcare provider. And I'm trying to get at kind of exactly that. What are the roles that people take? How did you get here? And how does this change over time? I think it's hard because people don't know, so in that very initial qualitative work I did about this, I would ask kind of these dyads of family caregivers and paid caregivers or individuals themselves, if people didn't have dementia and their paid caregiver, I'd say, when you guys have a good relationship, like how long did it take to get there? And the range of responses was really wild. I mean, there was one, there was sort of like an odd couple. The paid caregiver spoke Spanish and the patient herself did not speak any Spanish. So they communicated very little, but both of them said that, I knew from the first day, we clicked that first day. So there was that. And then there was a paid caregiver who was like, yeah, at about 3 years, that's when we kind of hit our stride. And so I think the answer is that I don't know, but I think it is really important to understand that, because to me, that's one of the spots where the kind of workforce literature and the workforce push around paid caregivers has a lot of interest in continuity and stability, because from the perspective of agencies who have paid caregivers, turnover and changing cases adds to cost. They don't want that. They want people to be in stable relationships. So I think that's something they value, and quite clearly families value that as well. So I think that's an example of where those interests are aligned, and perhaps by joining forces we can kind of promote those sorts of stable relationships more.
Thank you, Jenny. This is so important, this work, and we know so little, and so we really appreciate all the ways that you've looked at caregiving, and both in the paid and the informal space. And I think the other big takeaway for our investigators is the way that you looked at caregiving and continue to look at caregiving from a number of different perspectives, from a quantitative perspective, from a qualitative perspective, from a number of different sort of points of view. And I think that's really helpful to think about when we're trying to answer important questions like these. I also want to thank our leads for the PCRC Caregiver Corps for being a part of today's webinar, and would like to open up the floor to them. Betty Farrell, who is the director of the Caregiver Corps, and Nick Dion-Oden, who also works closely with Betty in the Caregiver Corps, would love to turn it over to you for any announcements or anything that you'd like to add, reflect on with respect to either Jenny's talk and the Caregiver Corps in general.
Thank you so much, Christine. Hi, everyone. I don't know if you can see me. I don't think you can. My camera's not activated, but let this be your infomercial for the PCRC Caregiver Corps. For those of you not familiar with the Caregiving Corps, we would like to entice you to learn more. Here's what we do. We try to assist and discuss opportunities to include caregivers in your palliative care studies that involve patients. We're here to help you explore areas of science needed to advance understanding of caregiving and palliative care. We also, and this is how I think we help people most of all, we assist investigators by helping them one-on-one in the selection of conceptual models, study design, outcome variables, and measurement tools as folks think about research they would like to do involving family caregiving. We're also happy to discuss opportunities for the inclusion of qualitative data in caregiving research. If folks would Google PCRC Caregiving Corps, you could go to our site, and the site itself has a lot of really valuable resources from presentations, and Jenny, really great job. Perhaps we can see if we can get your presentation included on our site. We have recommended reading for folks who are just coming in to the caregiving research space. We have listed a number of systematic reviews for all different types of family caregivers, from dementia to cancer to heart failure. We also, and I think we also help folks a lot with this in terms of selecting instruments used by family caregivers. We have several assessment inventories, including our own, that we've compiled over the years. We have sample proposals that are focused on family caregivers. So if you're wondering how to spell out those aims or argue for the rationale of a significant section, we have examples. And we also have a variety of other resources if you go to our sites, everything from methodological considerations to conceptual models. So would love, Betty, I believe you're on. Please correct me with what I got wrong and add what I missed.
Sure, thank you. Again, I just want to add my thanks for this outstanding presentation. As I was listening to it, I was thinking, this could be a model presentation for, anyone to step back and just talk about what is unique to palliative care research, because I think so many issues that you raised about the measurement issues that you've dealt with paid and unpaid caregivers, the need for both qualitative and quantitative approaches, the conceptual issues. It's like everything in your presentation are really the challenges for our field. So I think it's wonderful, and I'm glad Nick also mentioned how great it would be to get your presentation added to our core, because we really don't have much focus at all on paid caregivers. In addition to the things that Nick just mentioned that the Caregiver Corps specifically provides, as you were speaking, I was also reminded of the synergy across corps within the PCRC. And so in addition to our Caregiver Corps, as you were speaking, I was thinking that so often investigators start out to do caregiver studies, but then they realize, or a study section tells them, you need to also have some patient data and or even some patient measures to correlate with the caregiver outcomes. And so I was just thinking about the fact that PCRC also has the outstanding measurement core, which provides instruments that caregiver researchers might want to look at in terms of patient outcomes. Again, I love the qualitative examples that you included, and so the measurement core also has some great resources on qualitative methods to include in studies. Also, the data informatics and statistics core would be so valuable for studies such as yours. the mixed methods we're always reminded of, just in, the beauty of your qualitative data, that how much better our science is when we use mixed methods for palliative care. And so our data informatics and statistics core has developed such great resources. And for any of you who haven't looked on the site and specifically interacted with Salima Magami, who's been a lead on the qualitative and mixed methods and resources she shared, I mean, you're really in for a treat there. And finally, clinical studies. This presentation is one of those that I'm sure some of you sit and listen to somebody present their research, and on one hand, you're really impressed, and then there's a little part of you that thinks, oh my gosh, I'm so glad I didn't have to do that study, because, we realize it's not easy, the things that you've done, and the relationships between patient and family caregiver and paid caregiver. And so your work is really, really lovely and so important. And our clinical studies core can also help with just the design issues and conceptualizing how, what are the real practical issues of doing work such as this and designing studies such as this. So, your study really reminds us of all the things why we need a special PCRC, why we need special resources for palliative care, and fortunately all the great cores and resources that are there. So thank you for your presentation, and we're very happy that we can hopefully share your work on the website as well.
Thank you, Nick and Betty, and thank you, Jenny. What a wonderful infomercial for the Caregiver Core. And we do always load all of the webinars on the Investigator Development Center arm of the website. I don't know that it should be a problem for us to have it in both places, so we'll look into figuring out how to do that as well. Would love to turn over the final moments that we have together to Naomi to give you a brief insight into next month's webinar. Naomi?
Thank you. Thank you to everyone who's joined, and especially to Dr. Reckrey and all of our PCRC representatives for joining today. If all of our attendees do go to our website, we have one more webinar posted for the near future. And that webinar will be with Dr. Dina Schulman-Green to discuss her PCRC pilot project and tips for conducting qualitative interviews in the palliative setting. We hope you join us for that as well. We'll also be sending out an evaluation where we gather other topics that you might be interested in learning more about. We'll investigate that faulty link that was mentioned in the chat and attach the new link to that evaluation as well. So please take a minute to fill that out. And thank you again to our panel and for our attendees for joining. Take care, everybody.